Okay. All right, let's start with the mouth. Okay, so in the mouth we have salivary glands.
Are we supposed to be seeing your screen?
Yeah, let me share that. Okay. Is that better? Hopefully.
Yeah.
Great. Okay. All right. So we have the parotid glands, sublingual, and some submandibular. Okay. So um, we're also getting into one of my favorite things to help people with, and that is gastrointestinal dysfunction. So, um, so let me give a quick note on that. So, when you have GI dysfunction, okay, it's either going to be because of some legitimate issue like um, a congenital anomaly, or you're missing parts, or parts aren't big enough. Okay, the tubes are routed funny, which we'll talk about some of those stuff coming up. Um, so, in other words, you can't really help that if you're born with, or your body just made the gastrointestinal parts that had some congenital issues with them, structural issues. Okay. Uh, the other thing would be what, at least on our side of the fence, what we call space occupying lesions, or SOL. Okay, and SOL could be interpreted two different ways: space occupying lesion, or the other one, which they kind of both mean the same thing. It sucks to have some sort of lesion in your gastrointestinal system, and for that matter, a lesion anywhere in the body. Okay, and those can be from, cancers and tumors, and just anything, any kind of abnormal growth and abscess, polyps, whatever that can cause problems. Okay. So that is on one side of gastrointestinal, your anomalies and space occupying lesions. Okay. Now, the other side, and that's where I come in, or someone like me comes in, and that is under diet and lifestyle. Okay. Now, the reason why I'm starting with this is because this is going to be the groundwork for hopefully teaching people overall health as it pertains to their gut. Okay. So, a couple things here for diet and lifestyle. Okay. So, number one, it is how people eat. Okay. So, how people eat, such as incomplete chewing. Okay. Incomplete chewing. Um, and then the other one is what? people eat. Okay, so how people eat. Also, do they eat stressed? Okay, are they eating late at night? Um, you know, that kind of thing. So there's a lot of techniques on how people eat and then what people eat. Okay, so artificial foods or fake foods, pro-inflammatory. Okay, pro-inflammatory foods. Um, Fast foods, artificial foods, additives, preservatives, foods doused with chemicals and pesticides, genetically modified foods, and so on. Okay, so what people are eating. All right, now also understand that um, chemically, foods are made to trick the brain, okay, to trick the brain into thinking this is good. All right, so believe it or not, there are engineers out there and chemists and things like that that create different additives that go into food, and they are put there on purpose to make it addictive, to make the brain and the taste buds on the tongue and all that neurological connection and the different chemical reactions make it appear that this is actually good. Okay. However, once it gets into the gut, then it's not good. So even though your taste buds might think this is amazing, once that food gets into your stomach and then gets into your small intestine, it is actually an irritant. Okay. And when that happens, you're going to create inflammation. And this is the key. You want to destroy your gut and then inevitably destroy yourself, right? Go ahead and just create as much inflammation as possible. All right. The more inflammation you create, the more devastating things are going to be to your body. All right. There's also this thing called the gut brain axiom. Okay. You also might hear it termed as the second brain. So your gut is the second brain. Okay, so the gut brain axiom or the gut as the second brain. And there's growing research that's talking about all this. This is an area I focus on pretty hard in my clinic as I work with people. Okay, so my version of this, I can't really deal with the tumors and the congenital anomalies and tubes and all that kind of stuff that's all busted. Okay, I have caught those. I've ordered imaging studies and different contrast dye mediums and things like that, refer out, and we find all sorts of weird, creepy things. And then, I have to send to medical management because they need surgery, or, there's, the hernias and all this stuff. I mean, those are obviously surgical repairs. Okay. Your tumors, your polyps, your cancers, and so forth. That's not really something I deal with. That's going to be more of a surgical thing. All right. Now, what on in my world, what we focus on is this part. Okay. Now, in a nutshell, here's how it works. Number one, we do a history. Okay, and that's going to get into diet. So what they're eating. Okay, how they eat. All right. So what you're eating, how you're eating. Okay, we get into all that. All right. And then we start doing, so I have all these questionnaires, okay, that help. It's about 150 questions. Sounds like a lot, but it goes by quick. Uh, and it's a very good questionnaire system to start diving into diet and lifestyle stuff, okay? It's also very revealing. As people are filling it out, they're like, wow, I didn't realize how, what's really going on in my life. Okay. And I didn't come up with the questionnaire. That was done through research, and these functional medicine people figured out the best questions to ask people to get the most information. That's where it came from. All right. So then the second thing we start doing is labs. Okay. So I look for antigen, antibody, which basically, another way of saying this is I'm looking for different inflammation markers. Okay. And so we're looking at the body to see how inflamed you are. We're also doing genetic testing. Okay. For example, HLA DQ. Okay. That is a genetic test to see if you have a genetic predisposition for celiac disease and if you're allergic to gluten. All right, would be an example. So we get into genetic testing, of course, the celiac panel, and like a regular full panel. Okay, and then we'll just say a regular full panel. Okay, and what I mean by that is this is looking at your CBCs, your lipids, your metabolic panel, urine analysis is involved. It's looking at thyroid. Okay, it's looking at glomerular filtration rate, and so on. Okay, so it's about 80, I think it's 88 or something like that, 80 something different labs that come with our full panel. Okay, so it's kind of like the same panel you would get if you're getting a really good physical. Okay, you go in for a physical, they listen to your heart, blood pressure, take, vitals, all that stuff, and then they do a really nice lab panel. All right. So once we get all this information, now we have a very, very good starting point. And by the way, this antigen antibody, another, in lay terms, that's food allergy testing. Okay. And then what we look for with the food allergy testing is your IgEs, IgG4, IgG, and your C3Ds and blocking potential. Okay, so those are the labs that come with that antigen antibody complex, specifically looking for inflammatory markers in your body, and your body is telling us what foods you are allergic to and or what you're sensitive to. And that is extremely important information, because people are consuming foods that are creating massive amounts of inflammation. You keep doing that over time and you're going to destroy your gut. Okay. And if your gut is hurt, you're going to hurt everything else. Like, for example, the brain. Okay. You'll have decreased serotonin levels, which will lead to depression stuff and other eating disorders. You'll have disturbed sleep wake cycles. Um, your body's not metabolizing amino acids and other things properly. It can lead to diabetes, type 2 diabetes, with poor glucose regulation. The pancreas starts to work in overtime, and the gallbladder, the liver. I mean, it hurts everything. You hurt the gut, you're gonna hurt your body. Okay. Now, people manifest allergies and sensitivities to food and gut disturbances differently. Some people, their body breaks out in hives or some form of skin rash. Some people, the pain goes to their joints and it mimics arthritis. Uh, it can mimic lupus. It can mimic other autoimmune diseases. It can create ringing in the ears, which is tinnitus, cottonmouth, insomnia, brain fog, okay, irritable bowel, poor bowel movements or abnormal bathroom cycles and that kind of thing. And I mean, on and on it goes. It's terrible what happens to your body when you hurt your gut. Okay, and people don't realize how toxic some of the foods they're putting in their body really is. Okay, and when you talk to them, it's like, but it tastes good. It's like, I know it tastes good. It's engineered that way, but once it gets into your actual gut, it is horrible for you. Okay, so we're going to look at some of that stuff throughout today. Okay, a lot of it is going to be a line crosser, which means once you um, get hurt to a certain degree, then you're going to need medical management. So we're going to look a lot at that. All right. Also, we have to throw in here the other thing that hurts the gut is drugs. Okay. There's obviously a lot of side effects that comes with drugs. You can hurt the kidney. You can hurt the liver. Okay. You can hurt the stomach itself. Okay. For example, NSAIDs. Okay. You start taking too many NSAIDs and you're going to risk ulcers, right? Gastrointestinal bleeding, which you can also hurt the kidneys. You take too much Tylenol, which is acetaminophen, you're going to hurt the liver. And the liver is highly involved with our digestive system. Okay. Um, and then too much antibiotics, right? So you start to decrease the gut microbiome and throw that out of balance, you're going to get hurt. Okay. So, in other words, side effects of medication. And it's just something to consider. So, I have a patient in front of me and they're all messed up and we're getting into the history and it's the usual suspects. Okay. It just is every time. It's a mismanagement of drugs, too much of everything. Okay. They're eating foods that they shouldn't be eating. The inflammatory markers are all over the place. So they're too high and they keep promoting more and more inflammation because of what they're eating. They eat stress. They eat when they're not supposed to. Okay. Too much alcohol, too much soft drinks, too much sugar. I mean, that's very common. You see that in a lot of people. So what we try to do is we try to turn things around. Okay. Now listen, compliance goes up tremendously. I'm not kidding. I've been doing this a long time, 16 years. Okay. Of helping people with diet and, gastrointestinal disturbances and all this stuff. Now, listen, compliance goes up tremendously if you do the labs. Okay. If you do the labs, now these labs, these results are staring them in the face, and it's harder for the person to ignore it once they see what's going on. Okay. It's almost no different than my shoulder hurts. All right. And then the pain isn't going away, and we take an x-ray and it's like, whoa, look at that giant cell tumor. You've got cancer in the bone in your shoulder. Okay, now what are they going to do? It's not common for someone to be told, hey, you've got cancer, and then they go, well, let's do nothing. Okay, now they know. Or you fall funny and you hit your hand and your hand hurts, right? And a couple of weeks goes by and you're like, man, my hand just the pain won't go away. So then you go get an x-ray and they're like, your hand's broken, right? What do people do? Well, they want it fixed. Okay. Once they know, it's a game changer. Okay. This goes with just about everything. Once you know, because of tests and labs and images and studies and things like that, now it's a game changer and compliance goes way up. Okay. Otherwise, compliance sucks. If you just tell people, hey, stop eating that and start eating this, they're going to go, psh. Like compliance is almost 0% when you just talk about it. Okay. But once you get labs and studies and all that, compliance goes way up. So that's why we do it. Plus, it makes your game plan more accurate, very accurate. Okay. Once you get your labs and your studies, It makes the game plan very accurate. Okay, so going back to the mouth, and the reason why I also went on this tangent with diet and lifestyle, how people eat. Okay, well, guess what? Digestion starts in the mouth. Okay, so you must chew your food completely. Don't just inhale your food. All right, so digestion boils down to basically two things. Okay, and this starts in the mouth. All right, so there's two parts. To digestion. You have mechanical and you have chemical. Okay, so mechanical and chemical, and both of those start in the mouth. You chew your food, so that's mechanical. Now people can have teeth problems. Listen, I can't even tell you how many times I've caught teeth problems. Now, I'm not a dentist. I don't specialize in teeth. But when you're interviewing people about their GI, you're like, well, why are you just inhaling your food? Well, it hurts to chew. Okay, why does it hurt to chew? Well, my teeth, every time I get pressure on the teeth, it sends this radiating pain through my whole jaw and up to my eye and my ear and my whole head. And I'm like, okay, how long has this been going on? I don't know, about 5 or 6 years. I'm like, okay, all right. Have you had anybody look at that? No. Well, then how do you how do you get by? Well, I just don't chew. I just take a bite and just swallow it. I'm like, okay. All right. So I grab a pen light and I open their mouth, get their tongue depressor out. And of course, they're going to point to where it hurts. And so you just take a look and you're like, good grief, these cavities and these holes and these periodontal disease things and all these problems going on in the mouth and in the teeth and whatever. You're like, oh my gosh. So, of course, I'm going to recommend going to see a dentist, but I don't know. Good luck with them going, right? So, yes, I've caught these things where one of the reasons why people chew, they're not really chewing their food is because their teeth hurt. And then they're ignoring that. Okay. So, and then other reasons is just technique. Everything's fine in the mouth. They're just not doing it properly. Okay. So, anyway, talk to them about chemical and mechanical digestion starts in the mouth. Okay. So your saliva glands, the parotid, the sublingual, and submandibular, okay, these do release enzymes to help break down food. Now, keep in mind and write this down in your digestive system, enzymes speed up a reaction. Okay, so your digestive enzymes are going to speed up the breakdown of food. Okay, and one of the clues that you're dealing with an enzyme is if you see the word ACE. Okay. So if the word ends in an ACE, it's going to be an enzyme. Okay. So part of the saliva, you'll find amylase. Okay. Which breaks down your starches and some carbohydrates. Okay. All right. So now let's look at the stomach. Okay, I'm going to try to draw a picture here. Okay, so there's the esophagus. All right, this is your stomach, and this would be the small intestine. Okay. All right, so one of the cells in the stomach is called the chief cells. Okay, and it releases pepsin. Okay, and pepsin digests your proteins. Okay, my favorite one is the parietal cells, another cell in the stomach. Okay, parietal cells, because it releases your hydrochloric acid and intrinsic factor. Okay. Okay, so hydrochloric acid, when that pepsin is released and hydrochloric acid it released, it actually takes pepsinogen and converts it into pepsin in the presence of that HCl. Okay. And then your pepsin is going to break down the proteins into their individual amino acids. Okay, I'm also going to throw in some patho stuff here. So we'll talk about some normals like we're currently doing, and then throw in some patho stuff. Okay. Intrinsic factor.
Sorry, what is the under protein AA? What did you say that stands for?
Amino acids.
Amino acids. Okay, thank you.
So your body, one of the underlying goals is to take your proteins that you're eating, and you want them to be broken down into their individual amino acids. Now, it's a complicated process to get there, okay? But that's the long-term goal. You want those amino acids. Okay, intrinsic factor, which is okay, a type of protein. Okay, now here's the thing. It binds to B12. Okay. And aids in its absorption. Okay, binds to B12 and aids in its absorption. Okay, a deficiency of B12 is called pernicious anemia. Okay, pernicious anemia. All right, pernicious anemia and deficiency of B12 can lead to megaloblastic anemia. Okay, the reason for this is the inhibition of DNA synthesis. Okay, because the bone marrow is inevitably hurt. Okay, so the nucleic acids in the bone marrow nucleic acids decrease in synthesis. Okay, and this leads to the stem cells okay, so the pluripotential stem cells get hurt. All right, and these are the ones that inevitably create your myeloids and your lymphoids. Okay, and the myeloids are what create your red blood cells and your white blood cells, and the lymphoids create the B cells, the T cells, and the plasma cells. Okay, now think about that, right? You start hurting the myeloids and the lymphoids, and you've just devastated your system. And in this particular case, it's traced back to the gut. Okay, now, how do you hurt the parietal cells? How do you hurt the parietal cells? Well, one way of hurting them is taking proton pump inhibitors, okay, PPIs. All right, now one of the reasons why people will take PPIs like Nexium is because they have acid reflux and, you know, heartburn and things like that. Okay, now keep in mind, I see this a lot, right? So people come in and that's one of their signs and symptoms. Now, I'm not convinced that the reason why they're having heartburn is because they're PPI deficient. Okay, no one has been able to convince me of that. And I understand why the medication exists. I understand why people are on it. But what I think is better is to get them off of the foods that's promoting the acid reflux and the heartburn. Okay, now if you think about it, at the end of the day, you have one of two choices. You can continue eating the foods that's hurting you and then take the medication, or stop taking the foods that's hurting you and you're off the medication. That's kind of it. Those are your two choices. Okay. And so what we end up doing is we end up finding the foods that are hurting them and finding the things that are shutting down the parietal cells, and then we rebuild it. We get the parietal cells, we get the hydrochloric acid functioning again, and we get the intrinsic factor working again. Okay. And then long story short, things start to get better. Okay. We'll come back to that. We'll come back to other things that happen with decrease in HCl and intrinsic factor. All right. So once you start to hurt the B12 route, okay, and the inhibition of DNA synthesis and the decrease of nucleic acid synthesis, all right, now all of this, you're at risk for this condition called hypochlorhydria. Okay, this one is very common. Okay, and what it is, it's a decrease in your HCl, a decrease in hydrochloric acid release from the parietal cells. Okay, so if you have a decrease in hydrochloric acid, then you're going to have incomplete breakdown of proteins. Okay, because one of the functions of the hydrochloric acid is to help to unravel the proteins into their polypeptide chain, right? So proteins are usually these big convoluted balls. Okay, and then what happens is your body is supposed to open them up, and then what happens is you're supposed to break them down into their individual amino acids. Okay, like tryptophan, for example. Okay, tryptophan. What does tryptophan synthesize? Serotonin and melatonin. Oh, you're not feeling well. And I don't mean nausea stuff. I mean like depression and just overall feeling of, sadness and that kind of thing. Well, let's put you on selective serotonin reuptake inhibitors. Okay. Let's not work on your gut. Let's not work on the fact that you're significantly tryptophan deficient. Okay. And let's just give you some SSRIs. All right. Oh, and you're not sleeping well? Okay. Well, your sleep-wake cycles are off. Never mind that you're actually not making any melatonin because you've got a busted gut and you can't synthesize tryptophan. So let's just put you on different, let's put you on Ambien, okay? Because that's the main reason why you're not sleeping. Oh, and let's not forget that everyone is operating out a sympathetic nervous system, constantly in fight or flight, constantly releasing cortisol, risking adrenal burnout. How well does your digestive system function when you're in sympathetic nervous system? Okay, the answer is it doesn't. Your digestive system actually shuts down during sympathetics. And then you take a step back and you look at our culture and you look at people and you look at what's going on. And just this alone, constantly in epinephrine, norepinephrine mode, constantly stimulating the alpha androgenic receptors in the vessels, right? Which in the gut shut it down. And they're eating food, of which is not good food anyway. I mean, yeah, we're a mess. The gut is a mess. People are falling apart because of the stuff we talked about in the beginning. Okay. It is how they eat and what they eat. Okay. So you can start with the basics with people, which is chew your food completely. All right. Then you can start with putting proper food into your body, staying away from the bad stuff. Okay. Then you can do your labs and start to figure out exactly what's falling apart in their system. Their own body chemistry is telling you what's falling apart. And then you fix it. All right. And I'm giving you one example here, which is the parietal cells and the chief cells and the different cells in the stomach. They are relatively dormant. They're not releasing the stuff that they're supposed to release, and there's side effects from that. Okay. Now, the knee-jerk reaction in our culture is just to take Tums and Nexium and Rolaids and things like that. Okay, which believe me, I understand. I understand why people are doing that. Okay. But at least in my world, I don't want you to have to be on that stuff for the rest of your life. Okay. I would rather you not be on it. So we're going to do the best we can to turn over a new leaf. And then also what we're doing is years down the road, we're trying to prevent you from getting tubes in your stomach removed, you know, the diverticulitis and all the other problems that you're going to get that we'll look at, you know, later today. All right. So hypochlorhydria is a very common condition. And that is decreased hydrochloric acid. Okay. Another one is celiac disease. Okay, now the list that I'm putting on the table here is in no particular order. These are just things that you can get from a busted gut and consuming the wrong foods. Okay, so celiac disease. Another one would be hypersegmented neutrophils. Okay, hypersegmented neutrophils. Now keep in mind, we just looked at the myeloid route, right? So if you hurt the stem cells, you may not be producing your white blood cells properly. So there's a lab to show you that you have neutrophils that are not coming out right, likely a bone marrow issue. Okay, we'll keep going down that route. Maybe leukemia is around the corner. Okay, so you start hurting cells enough and messing with stem cells enough and creating enough inflammation. Yeah, at some point, cancer can be around the corner. Okay. You'll have a decrease in folic acid. Okay. Now, a decrease in folic acid can lead to those neural tube defects and can be during embryological development, could create some problems, right? Embryological development problems. Leukopenia. A decreased immune system. Okay, so leukopenia and also leukemia. Okay, IBS, malabsorption. Diverticulitis. Okay, fistulas. Pancreatitis. Okay, neurological problems. Okay, this is also called combined system disease due to a decrease in B12 or significant B12 deficiency. Okay, it can also cause demyelination. Okay, so the myelin that's on your nerves, okay, that come from the Schwann cells and the oligodendrocytes, those can get hurt. Okay, things that don't help. Okay, adding insult to injury. Going back to our drugs would be increase in your NSAIDs, too much antibiotics. Okay, I get it. There's a time and a place for NSAIDs and a time and a place for antibiotics, but people are just wearing this stuff out way too much. Okay, and the increase in antibiotics and we'll actually look at, I think that was one of your questions this morning as well, on your quiz question, right? You're going to decrease the healthy, the good microflora, the good bacteria in your system. You're also getting rid of that. And then you create an imbalance in gut microflora. And now you're an open door to all sorts of opportunistic organisms and pathologies and problems. Okay. Also, when you decrease your hypochlorhydria, okay, so you're going to get risk for H. pylori, okay, because the acidity destroys the bacteria, all right, and fungus and stuff like that. You're also going to risk getting an increase in candida, okay, and I test for these things. Okay, it automatically comes with the package of the labs that we do. We get an H. pylori test to see if there's bacteria, and we see if there's an overgrowth of candida. And guess what? Yes, every time, well, not every time, just about every time, these come back positive. Okay. All right. So the NSAIDs, a side effect of that is well, let's just do GI bleeding. Okay. Gastrointestinal bleeding, ulcerations. I'm very careful in my coaching with my patients that are taking NSAIDs. Okay. I show them the recommended dose per day, and then based on their body type and their body weight and all their age and all that kind of stuff and their pre-existing conditions, how many milligrams per day and over a certain length of time before now you're going to start getting, now you're really flirting with danger. Okay. Like, for example, if a person, they're pretty sore, they're pretty banged up, for whatever reason, and, because they did some weird, you know, like backyard football or something, and it's not really their thing. And they was like, all right, I'll come over and play. And they play really hard, and their body's not used to it. And they get tackled and hit and all this stuff. Right. And they wake up the next day and they're like, oh my gosh, I'm miserable. They're so sore. And they take like 600 milligrams of ibuprofen. Okay, fine. Not really a big deal. Okay. And that was kind of one and done. And then you've got these other people who their knee hurts, but they got to do their run and they got to do their CrossFit and their hiking and all that stuff. And they're taking, 800 milligrams in the morning, and then 800 milligrams midday, and 800 milligrams in the evening, and 800 milligrams before they go to bed. And they've been doing this for like 2 months. And you're like, what the heck? Okay. So those are some examples, and you have to talk to them. It's like, look, you're taking way too much. You're going to get hurt. Okay. So also what happens with, once you start getting into some of the conditions that we wrote down, okay, usually you're going to find that people might be on methotrexate. Okay. And methotrexate it damages folic acid. Okay. So it damages folic acid. And then what that does is it hurts the purines. Okay. And the purines are the building blocks to DNA. And RNA. Okay. And so if we can help it, now usually reach out to the prescribing doc and say, okay, hey, patient so-and-so is on methotrexate. Here's some of my findings. I think the reason why they're on the methotrexate to begin with is because of the side effects from their lifestyle. Now we're trying to fix that, and we're fixing the busted gut part, which means we can get them off the methotrexate. Okay. So, some of these things were co-managed to try to wean people off these things. All right. Because in the long run, you're going to get hurt. Okay. All right. Now, if you're curious on how to help get those parietal cells kick-started again, so treatment is going to be, I actually give them hydrochloric acid. It's in capsule form. And then we give them proton donors. Okay, so they're on the PPIs, right? The proton pump inhibitors. Now think about that. Proton pump inhibitors. Inside the cells in the stomach, those are the pumps, and they need protons to work. So we're trying to get them working again. So we get them off of the inhibitors and give them promoters. So the proton donors, and then get them on digestive. Okay, then we get them on digestive enzymes. Okay, and change their diet. Okay, now I'm also giving you the simple version here. There's more to it, but this is some of the basics, and the basics go a long way. Okay, so through the labs, we're getting them off the stuff that is promoting injury, promoting inflammation. Okay, and then we're weaning them off the medications, and then giving them things that actually start promote more GI function, like digestive enzymes, hydrochloric acid, the proton donors. Okay, also part of the labs is we look for deficiencies. Okay, potassium deficiencies, sodium, magnesium, calcium, your B vitamins, and your fat soluble vitamins like vitamin D, and so on, right? So we're also looking for deficiencies. Okay, any questions on this part that we just covered with mouth and stomach? Okay.
I had a quick question.
Yes.
For the methotrexate, you said that the folic acid decreases, or the methotrexate harms the folic acid in our bodies.
Yeah, so
So-
methotrexate is a DNA synthesis inhibitor. Okay. So now keep in mind, one of the reasons why some people are on it is because they're likely dealing with cancer. Okay. And part of chemotherapy and part of an immunosuppressive drug, it can help treat cancer, okay, and a variety of forms of cancer, blood cancer, bone cancer, lung cancer, breast cancer, and so on. Okay. Now, if I'm dealing with a cancer patient, I am, hold on, let me think about this. I'm just trying to think about how to say it. I'm more hesitant to change their medical protocol because of the nature of the situation. Okay. So they have cancer, they're doing chemo and all these things, and I still work with them, but it's a whole different ball game when you're dealing with a cancer patient. Now take that and switch it over to, we have a, let's just say a normal person, no cancer, no weird things going on, okay, except these modern everyday just blah, right? Just my stomach hurts, I feel like crap, I've got brain fog, I'm not sleeping well. But at the end of the day, they have nothing creepy going on. They don't have a brain tumor. They don't have all these severe things that we're going to get into after a while. It's just all side effects of a poor lifestyle. Okay. Now, once I get that kind of a person, now it's more open game. We can do more stuff, and I'm not worried about hurting them because I'm not dealing with cancers and things like that. Okay. What happens is when you do a review of their systems and you do a review of their medications and all that kind of stuff, you'll find that some people have actually been prescribed methotrexate. And here's why. They were misdiagnosed with rheumatoid arthritis. Okay. And what I mean by misdiagnosis is their joints hurt, but there's no evidence, full-blown evidence of autoimmune rheumatoid arthritis. And what happens is the prescribing doc says, all right, you know what? You have all this joint pain. We've done every test. We can't find evidence of rheumatoid arthritis. So we're going to just go ahead and treat you for rheumatoid arthritis anyway. And one of the things we're going to put you on is methotrexate. Okay, then I get them. And then we do all these tests I just told you about and find out that their particular metabolic pathway of the inflammation from the side effects from the gut inflammation in the food is actually going into their synovial joints. It's like, okay, we just found the problem. Now it makes sense why they could not find bona fide evidence of rheumatoid arthritis, okay? But you have joint pain and your knees are the size of softballs, right? But now we found why. So what I do is start to wean that person off of the methotrexate because they don't need to be on it. We're not dealing with cancer or immune suppressive stuff. I also know that their current state of gastrointestinal dysfunction, the crap that they're putting in their body, the inflammation, now combined with methotrexate, is going to devastate their DNA synthesis, which means in the long run, we're going to have more complications, okay? Because one of the things that drug is engineered to do is to slow down DNA synthesis, and it does it via the purines, right? It basically blocks the purines, which are the building blocks of your DNA and RNA. Now, and when you go back to your cell phys, like we need that. You need the nucleus of the cells to constantly be in communication with your messenger RNA and the tRNA and the DNA synthesis stuff, and the double helix is peeled apart, and the transcription and the all that stuff that happens, like we need it. And you're actually slowing this down through the medication, okay? In this case, all in the name of, it's because they have a busted gut because of diet and lifestyle. Now, to me, that's worth switching gears, right? Now, if it's a cancer person, whole different ballgame. Okay, we go down a completely different route, and it's more complicated. But and then if you look up methotrexate, you look at the side effects, right? The number one side effect is gastrointestinal disturbances, nausea and vomiting, and they risk ulcers. Okay, they get headache, they get fatigue, right? So all these symptoms that you get from just having a busted gut to begin with, because you're not eating right, is now enhanced because of the medication. Okay, so so in my particular case, I'm a little bit more sensitive to trying to help someone with their gut. So I try to look at everything. Okay, so think about that. You're coming in because you have a busted gut, and now we're going to work together as a team to fix this. All right. I would be doing you a disservice if I recognize some of the things that you're on are hurting you and say nothing. Wow, this person's on all these different medications. Well, I'm not going to say anything. Like, that's not fair. At least put it on the table and let's see if we can safely wean you off of them. Now, if we can't, then we'll figure out a way to work with it. But if we can, then that's good. Okay. Now, please, pretty please keep in mind, I'm not anti-medication because there's a time and a place for it. But if you are on a medication you don't need to be on, that's causing major side effects, I think it's okay to figure out how to wean people off of that, if done safely and if done effectively. Okay. No different than if you are legitimately gluten intolerant and the gluten is hurting you, I think it's safe to say stop. Okay, because we've done the genetic testing, we've done the labs, everything is positive. Clearly, you have signs and symptoms of celiac disease stuff. I think it's perfectly reasonable to say what you're currently doing is hurting you. Let's try to turn that around. Let's stop, taking the meds or taking the food or taking the whatever that's hurting you. Like, that's fair. Now, at the end of the day, it's still up to the person. Now, I can sleep at night as long as they know. Like, now that you know, now if you make a decision to not do anything, then that's fine, because that's on you. At least you know. Okay, where I can't sleep at night is if I feel like I did somebody a disservice and you deceive them or you lied to them or you ignored something, okay, and they're on something and you're like, yeah, that's going to hurt them, but I'm just not going to say anything. Like, and that's just me. That's me talking. I'm not okay with that. All right. So anyway, did that answer your question in a very long way?
Yeah, thank you.
You're welcome. Okay, any other questions? Okay, so we'll take a little break, and when we come back, we're going to do a little bit of gallbladder and a little bit of pancreas and some other small intestine, liver, okay? Then we'll talk a little bit about some triglycerides and some other lipid stuff, all right? So I'm combining some normal anatomy stuff with some pathologies. Okay, so that's kind of what we're doing in this first segment. All right, well, let's take a 15-minute break. Okay, so we'll come back and get started in about 15 minutes. All right, see you in a bit.
Hey, Jonathan.
Yes.
Got a question about, so what's the difference between like a PPI and an H2 blocker as far as what's going to go on with everything we just talked about?
Difference between a PPI and an H2 blocker?
Yeah. So, I mean, like, would an H2 blocker essentially cause all the same symptoms and everything that we were just talking about?
That's a histamine blocker, right?
Right.
Yeah. Okay. So let's see. All right. When you have inflammation, okay, there's a cascade of events that happen. And so histamines can come in, leukotrienes, prostaglandins, cytokines, all that stuff. And one of the things, at least from the functional medicine perspective, that we focus more on is if a person has a history of being on PPIs, because we know what that did to the proton pumps inside the cells of the stomach. Okay. When you're on a histamine blocker, that here, let me draw this out. So there's a cell. Hold on. Okay, so there's a cell, and just to keep this simple, there's a receptor. Okay, and when inflammation happens, your body is going to release a histamine. Okay, so we'll just call this triangle for now a histamine, a bunch of them. Okay, and as you can tell, that histamine would love to bind to that receptor, and then once it binds, you're going to get your classic histamine responses. Now, an antihistamine will just block that site. Okay, it blocks the receptor site and doesn't really seem to be that big of a concern from a functional standpoint. Okay, so let's let's see, to undo a proton pump and years of someone being on a proton pump inhibitor is a lot more work than to try to wean some off of an H2 blocker. Okay, it doesn't seem to be as big of a fire to put out.
Okay.
Does that help?
Yeah, I was just wondering because my wife has actually been dealing with a little PPI. Yeah, she's been taking it for like 3 months now.
Okay.
And she was just asking if a histamine 2 blocker would actually be a better suit for her or fit for her.
Well, so one of the only way to know is to try, right? So I'm also a big fan of trial and error. If you can, like, I wonder what it's like to jump off this 3-story building. Like, don't try that, but within reason, some trial and error stuff. Is this med going to work for me, or is that med? Will this supplement work or that supplement? Will this rehab thing work or will that rehab? Okay. So a little bit of trial and error. Now, of course, to me, what's bigger than that is what's going on underneath all this stuff to have to take either H2s or PPIs, right? So that would be, just how my mind works, and the clinical side. I'm more interested in trying to get to the bottom line, behind the scenes, underlying factor to see what's going on. Okay. So anyway, with respect to that, sometimes that's also trial and error on the person's end. Like, for example, and this is on their own, no help, no coaching, no practitioner, no nothing. They're on their own. What happens is they'll go out to dinner, and let's say they have, something dairy for dessert, like ice cream or a shake or whatever. Okay, let's just say. And then they go, man, every time I have that dairy dessert, I feel like crap. And then it just kind of dawns on, well, let me try not eating, dairy stuff, see what happens. And then they feel fine. And then they have dairy again, and then they get hurt. Okay. And they kind of figured that out on their own. So that would be an example of food trial and error, paying attention to things that hurt you and things that don't hurt you. Now, that is a little bit longer of a process to figure out what's going on versus doing the labs. Okay. But it is a method. You can do like a food diary, a food journal, pay attention to what you're eating, introduce foods, remove foods, and just see what happens. Okay. So if you kind of do it on your own, that's a good start. And then you just go from there. Okay. And also for everyone, I wanted to say, comment a little bit deeper on the depression stuff that I brought up earlier. I had mentioned that tryptophan amino acid synthesizes serotonin and melatonin, of which it does. About 80% of serotonin is manufactured in your gut. And serotonin is, in simple terms, a feel-good hormone. Okay. And, but here's what I want to add. First of all, depression and mental health and that kind of thing is a big deal. It's a big issue. It's a thing. Okay. And there's many different forms of it, anywhere from, PTSD stuff to, abuse and just all the different traumas of life that can come people's way, and on it goes. Okay, there's multiple levels of depression and mental health issues and so on. Okay, so the reason I'm bringing this up is I don't want you to think that if you can improve the serotonin manufacturing in your body, then everything goes away. Okay, it's not quite that powerful of a magic wand. Okay, so but the reality is this. most people that are dealing with some form of depression, okay, irrespective of life circumstances, and everybody has their story. Okay, so in other words, it doesn't matter if it's military PTSD stuff to I'm going through a divorce to, you know, whatever the person's story is, it's all valid, and it's all it's their story. Okay, and it's very important to them. Okay, whatever it is that they're going through. And I'm not saying, well, hey, if we just get serotonin in your body, then all your problems go away. Okay, here's the angle. It doesn't help to have a busted gut and be serotonin deficient and add that to what you're already dealing with. Okay, that's ultimately what I meant by that. You know, earlier we were just getting into some very quick versions of this stuff, and so I just put that on the table. But on the break, I thought about it. I was like, I better dive in a little bit more detail to explain that. Okay, and so when you're dealing with mental health issues and depression, every single person in every single case needs to be handled, you know, best you can. Okay, because everyone's story is different. Sometimes it's just everyday life stuff like, oh, I'm going through my first breakup and my life is over and I'm just so sad. And no one has really told you, you know, and you're 20 years old and no one's really told you, you know, sometimes it just happens. Okay. That's part of life. Like we have loss and there's ways to handle loss so it doesn't ruin your life. Okay. And so sometimes you just have that talk, but it also doesn't help if that person has a busted gut. It just takes a bad situation worse, which is a little bit different than someone who's dealing with other legitimate chemical imbalances and, you know, the PTSD stuff and whatever. Okay, those are more serious because it goes way outside of just, oh, I'm going for the breakup for the first time, right? And now breakups suck, right? But they also there's a way you can navigate through them, and there's a way to overcome it and come out healthier in the end. Okay, so I just want to clarify that it does help a person's situation if they can be more chemically balanced on the inside and then go through other techniques to navigate through whatever it is they need to navigate through. Okay. And so I do work with some people that are dealing with depression and are dealing with certain, you know, issues like that. And on my end, what we try to do is clean up as much inflammatory things as we possibly can, because the decrease in inflammation in their gut and the increase in functional nutrition stuff helps their situation. Doesn't necessarily cure it, but it helps it tremendously. And then if they're going to someone else, whether it's a counselor or a psychologist or a psychiatrist or whatever, you know, then they're doing the best they can to help them. All right. So just wanted to clarify that. Let's see, where did we do? We did parietal cells. Okay. So next, let's look at gallbladder. Okay, so the liver kind of looks like that, and the gallbladder is in there somewhere. All right, so gallbladder. Okay, it's not really important if you draw out a liver. I was just doing it to give you a visual. Okay, the gallbladder Okay, it releases bile salts. Well, let me say that better. It doesn't release bile salts. Bile salts are synthesized, so made by the liver. Okay. And we get this from cholesterol. Okay, so in other words, cholesterol, one of the things cholesterol makes or synthesizes is bile salts. Okay, and its function is lipid digestion. Okay, it's almost identical twin cousin, bile acids. Okay, its function is to facilitate the formation of micelles. Okay, not spelled like ballistic missile. Okay, it's spelled differently. It means tiny morsel. Okay, now listen, the micellization process is a very important process of your digestive system, of the GI system, via the liver and the gallbladder. Okay, and one of the things that is absolutely important is the micellization process. Okay, and what this does is it helps you process dietary fats. Okay, and it also helps, which is huge, this next one, is the absorption of your fat-soluble vitamins, which is A, D, E, and K. Okay, and these are absorbed within the small intestine. All right. When you have, this is one of the reasons why we test for these, okay, because it's very common for people to have fat-soluble vitamin deficiencies, especially vitamin D, especially the form D3, which is cholecalciferol, okay? And they may be even consuming fat-soluble, these A, D, E, and K vitamins as a supplement, all right? The problem with that is most people have a busted gut, and most people will not be able to absorb the fat-soluble vitamins even though they're supplementing with it. So you have to be careful on the type of supplement that you take. Okay, so the best form to take is if it is micellized, okay, micellized and emulsified for you. Okay, so if they take the supplement and they missileize it and they emulsify it, then that is the form that you want. Because what they did through the engineering behind this particular supplement is the companies, and there's not that many of them, so this is kind of hard to find. But what they recognize is they're like, wow, people do have a missilization problem. They have a fat breakdown problem. Their body does not know how to regulate the dietary fats, okay, properly. Remember, the lymphatic system has 3 functions, right? Fat absorption, edema reduction, and immune system. And their lymphatics aren't working right. Okay, and on the list goes. And they know this through the research. This isn't just a guess. This is a lot of data that has been accumulated over time, and they just recognize this is a problem, okay? They also recognize, well, we can either fix everyone's gut, well, good luck with that, or we can make a supplement that we do all the work for you that your body was supposed to do, which is missileize and emulsify. So when you take it, it gets right into your system. It's got a very high absorption rate because they already did the work your body was supposed to do for you. Okay. So just keep that in the back of your mind. If you're ever in the market for yourself or for your friends, family, or patients, and you're going to make a recommendation, make sure they get a missileized and emulsified form. The best company out there is Biotics Research. Okay, they make the best missileized and emulsified form of your fat soluble vitamins. Okay, very cost effective and very good. Okay, they're the best. And I've seen all their studies. And what they do is they take people's blood and they measure everything before they get started with supplementation. They see where your levels are at. And then they take all these people and they put them on a variety of different brands. Okay, now the patient doesn't know, or the subject on this matter who volunteered for this testing, they don't know what company, what brand they're being given. They just know they're taking a fat soluble vitamin. And then what they do is they, give them the supplement stuff, and then down the road, they measure them again. And they want to see what absorption rate and the levels and all that kind of stuff. All right. And this company wins every time. So the ones that they make, very good, very cost effective. It's a liquid, so it's easily consumed. Okay. So, and there's some other companies that do it as well, but Biotics is the best. All right. Okay, back to gallbladder. Okay. Bilirubin is a product of heme degradation. Okay. If you have obstruction of bile flow, okay, you want to be thinking liver and gallbladder. Okay, obstruction of bile flow, think liver and gallbladder. And that's a clinical thought. Okay, so I get a patient and I'm worried about bilirubin stuff. Okay, you've got that fire to put out, but then I'm also thinking, well, then what the heck is going on with your liver and gallbladder? So then we go down that route. All right, if this becomes a problem, okay, you can get jaundice because of the increased bilirubin in tissue. Okay. And signs and symptoms is the person is kind of an orange, yellow skin color. Okay, kind of an orange, yellowish skin color. All right. Okay, the gallbladder stores bile. Okay. And what happens is when in the presence of fat, the gallbladder, which is smooth muscle, will, so the gallbladder will squeeze, so contract, and it ejects the bile through the tubes into the small intestine. Okay, so the gallbladder will squeeze, ejecting the bile. Then what happens is it takes fat plus water and it brings them together, and this is emulsification. Okay, because normally fat and water want to separate. Okay, so the emulsification process is one of the first steps in healthy fat breakdown. Okay. All right. If this doesn't work properly, all right, you'll get a condition called steatorrhea. Okay, steatorrhea is increased fat in stool, okay, in your stool. All right, because of the decreased ability of being able to digest and absorb your fat. All right, this will lead to your essential fatty acid deficiencies. Okay, also a decrease in fat soluble vitamins. Okay, A, D, E, and K. So back to taking a history on a patient, this is one of the things we look for is the loose stools, the floating stools. You know, most people don't, like a layperson wouldn't really realize, well, the reason why their stool is so loose and floating is because there's a lot of fat in it. Okay, that doesn't really dawn on them, but they'll tell you, you know, if you start diving into the history of their stool. All right, so if I pick up on that, you know, I'm now worried about gallbladder, bile salts, bile acids, liver, you know, what's going on, okay? So we start diving in, we look for deficiencies, we look for liver health, with your different liver enzymes, and on it goes. Okay. If we have to, kind of higher end is we'll start doing MRIs and all that to get in there to look at the integrity of of those organs. Okay. And every once in a while, I'd say about in 1 year, I'd say there's about 3 to 5 people in my world. Okay, in 1 year, about 3 to 5 people where it is creepy. Okay, space occupying lesions, tumor stuff, or just very strange, like twisting of the organs, whatever, just something not good's going on. And then, refer them out for that. Different hernias where the intestines are all protruding and just weird. Okay. And yeah, they're coming in with digestive dysfunction and all the other stuff. And, they hear that I help people with gastrointestinal issues. And so that's why they're there. But sometimes it crosses a line and we got to send them out. Okay. Now, once the surgeons and all that fix it, then we come back and was like, okay, now that you're better because they fixed all the weird stuff that was going on inside of your tubes, now let's dive into having healthier, lifestyle choices, especially when it comes to diet.
I have a quick question for you.
Yes.
So people with cystic fibrosis, we learned in farm that they get steatorrhea. How is that?
Meaning, why do they get steatorrhea?
Yeah, I guess I'm confused at how those two are related.
Let me think. Yeah, why would a cystic fibrosis person? Well, one of the things is because of the mucus problem that they have. Okay, so cystic fibrosis can affect mucus cells. And the next layer down is then it starts to affect the cells that create digestive juices. Okay, so then that means the long-term side effect will be poor absorption.
Does it not have anything to do with the pancreas?
Pancreas. Off the top of my head, I'm not sure at what point the pancreas gets involved. I do know the pancreas does have those same cells that the stomach has to create those digestive juices. So the pancreas, those particular cells would be affected. So yes, in that sense, because the different materials that make up the different cells that secrete digestive juices, found throughout the stomach and the pancreas, right? Also your saliva glands. So I can see that mechanism because it hurts those cells. Yes, it would hurt the pancreas. And that's why they would have, absorption and digestive problems. Usually first signs and symptoms are, lung issues, right? The limited breathing over time. And, cystic fibrosis is a genetic, like an autoimmune genetic thing with different mutations that go on. And as that process continues, then it'll go from lungs to then the different cells, like the mucus cells and digestive juice cells, and hurt that. And then therefore they would have digestive problems. Okay. And does that help? Okay. Steatorrhea. All right. So people that have had gallbladder removed, okay, people that have had their gallbladder removed, which I work with a lot of these. Okay, again, that's part of the history. Do you have your gallbladder? Yes, I do. Great. No, I don't. All right. So what happens is in that liver, okay, and the gallbladder was there. Well, the gallbladder was there. All right, just to kind of keep this simple, there's now a hole where the gallbladder was. And what happens is their body can still make and release the bile, okay? The liver just doesn't have any place to store it. So it's like constantly leaking out. So people that have had their gallbladder removed will notice that they're like, wow, every time I eat like a really fatty meal, like a pizza or something like that, their stools are just odd. You know, their stomach hurts, probably gas and bloating and whatever. And then, you know, stool problems. Okay. So then somewhere along the way, they come across someone and we start talking. Okay. I might be one of those people. And you start asking those questions and they're like, yeah, I've noticed that. And I'm like, and then you explain why. And then they go, oh, okay. And then it kind of makes sense to them. So then what we do is we just start to modify their fat intake. Okay. And so we talk about the mechanics of that and what it looks like. And then I also give them bile salts with digestive enzymes. Okay. And they take that with a meal, especially a fatty meal. And it does wonderful. It really helps. Okay. Now, obviously, you can't really fix a person that's had their gallbladder removed because it's been removed, but you can certainly work with what's left. Okay. All right. Next, pancreas. Okay, let's draw a pancreas. All right. And these are just randomly placed, okay? So alpha cells, okay, alpha cells release your glucagon, which stimulates your gluconeogenesis. Okay. The beta cells release insulin, okay, which helps with blood sugar levels. Okay. The CNR cells release your bicarbonates. Okay, into the small intestine. It helps buffer the acidity, helps neutralize stomach acid. All right, so let's actually write some of that out. So neutralizes some of the stomach acid. Okay, helps ionize Okay, helps the ionization of bile salts, which means it helps it to emulsify better. Okay, and it helps increase digestive enzyme activity. Okay, so CNR cells are pretty cool. Okay, if your bicarbonates are low, then steatorrhea, okay, and then I'm sure cystic fibrosis has something to do with starting to hurt those CNR cells in the pancreas. So their bicarbonates would be off, and that would contribute to some of the steatorrhea. All right. Okay, the pancreas releases certain digestive enzymes. Okay. Trypsin is one of them that helps break down proteins. Also, chymotrypsin, which also helps break down proteins. Okay, it releases the pancreatic amylase, which breaks down starches. Okay, which is a form of a carbohydrates. Also releases lipase. Okay, and that helps break down fats. Okay. All right, so cholecystokinin okay, this is one of my favorites. You'll see why. So the chol part means bile. Okay, the cis part means sac. And kinin means movement. Okay, this is where this word comes from. Okay, so cholecystokinin stimulates the pancreas to release its enzymes. Okay, like the trypsin, chymotrypsin. All right, it also causes the release of bile. Okay, so it tells the smooth muscle gallbladder to contract. Okay. Cholecystokinin is also a hunger suppressant. Okay, it is also synthesized or made in the small intestine mucosal endothelium. Okay, now here's the one that that I really like. Okay, cholecystokinin is inhibited by somatostatin. Okay, not necessarily a good thing, but that's part of the mechanism. All right, somatostatin is also known as a growth hormone inhibitor, a growth hormone inhibiting hormone. Okay. So somatostatin is also known as a growth hormone inhibiting hormone. Now, what happens is when a person is releasing too much somatostatin, then it will decrease the function of cholecystokinin. And now that you know what cholecystokinin does, you can get other problems. Okay. And in some central nervous system dysfunctions, okay, or some brain dysfunctions and some side effects of medication, somatostatin can constantly be released. Okay. So if you're constantly in the presence of somatostatin, you know over time cholecystokinin is going to be affected, and then you know you're going to have some gastrointestinal disturbances. Okay. So this is, if I suspect that, then we do labs, right? Then we'll dive in and do some fancier labs to look at the level of this. And then if we find that it is indeed high and inhibiting cholecystokinin, then we switch gears. Also, in youth, in kids, if you reverse this, okay, so currently the kid is experiencing a stunted growth. Okay, and I've worked with many of these cases, right? So kid comes in, the parents, he's like he's bottom of the totem pole. He's supposed to be, 48 inches or so, and he's not. He's like 30 inches and he's tiny, and he's in fourth grade, but he looks like he's in first grade. And, on and on they go with, signs and then and of course, by the time I get them, they've done the medical dance for forever. They've been to every specialist in the universe, and they've tried, it seems like everything. And I look at what they've done, because they bring in this huge stack of treatments and everything. And I'm like, okay, yeah, they've tried everything, but no one looked at somatostatin. Okay. So then we dive in. It's like, oh, look at that. And so we start diving down the route of getting somatostatin under control. And then cholecystokinin eventually gets restored to normal. And so growth hormone starts being released, because remember, somatostatin is a growth hormone inhibitor. And then they start growing like crazy. They're eating like crazy. Like everything starts to go back to normal. It's kind of cool. Okay. Usually not the first go-to, in any clinic. It's like, oh, it's somatostatin. I'm telling you, it's not the go-to. It's like way down on the list of the thought process. But if you can pull that card and you find it and it's a thing, you're really going to help the person. All right. Let's do a little bit of small intestine. Okay. So there's the esophagus. There's the stomach. Okay, kind of a terrible stomach. All right, the first part of the small intestine is the duodenum. Okay, the first part of the small intestine is the duodenum. This is where all the tubes come in. Okay, what I mean is the ducts, the tubes from the pancreas, from the gallbladder. Okay, all those tubes will dump their digestive juices and all that stuff into the duodenum. Also keep in mind, you've got the pyloric sphincter, okay? The pyloric sphincter, which holds the chyme. All right, so all this green stuff would represent the chyme, C-H-Y-M-E. Here's your analogy. You take a bunch of food, you put it in a blender, you turn the blender on and it liquefies it. It's kind of what your stomach does to food. You chew it, break it down into smaller components in the mouth. Chemical and mechanical digestion starts in the mouth. Then it goes down the esophagus, enters into the stomach. In the stomach, it is now, it continues with that chemical and mechanical breakdown. And then eventually it's liquefied and it turns it into chyme. Then the pyloric sphincter will relax and allow a little bit of that chyme to be entered into the small intestine. Okay. And then the sphincter closes off. So it only allows a little bit and then shuts off. Okay. So now that there's presence of chyme, or in even more layman's terms, food, okay, the presence of that in the duodenum, then that activates a bunch of different, digestive enzyme things and all that from the pancreas and the gallbladder and so on. And now the body is going to start chemically breaking down all the different components. And as this chyme is continuing to be broken down, okay, as it's passing through the small intestine, it continues to be absorbed, okay, by the microvilli and all that stuff. And we'll look at some of that later. Okay. All right. So in the small intestine, the brush borders of intestinal epithelium. Okay. are going to release lactase, sucrase, maltase. Okay. So the lactase the heck? Hold on. Breaks down the disaccharides. Okay. Your milk sugars. So that's why if a person is lactose intolerant, they likely lack lactase. Either genetically or they just have some sort of small intestine injury or whatever. Okay, sucrase.
Hey, Jonathan, I think you stopped sharing your screen.
All right, hold on. Okay. All right, did that come back?
Yes.
Okay, okay, good. So I was here. I did the lactose, breaks down your disaccharides like milk sugar. The sucrase breaks down sucrose. Okay, sucrose is your table sugar. And also helps break down fructose, which is your fruit sugar. And the maltase breaks down maltose, which is found in plants, plant foods. Okay. Also, it's important to know that we have simple columnar epithelial tissue that line your digestive system, the small intestine. Okay. And this is another thing that I test for, and that is called leaky gut. Okay. Now, here's what's happening. The simple columnar epithelium okay, and there's the nuclei. All right. The simple columnar epithelium, you want the borders there to be tight. Okay, you don't want them to be loose, and you don't want them to leak. If they are not tight and they open up, so an example of opening up would look like this. Okay. So now you see the space at which it opens up. Now what's happening when this happens is the food particles, the chyme stuff that your body is trying to break down, They're supposed to be inside of certain tubes, and that's where they belong. And if they're going to get into your body, they need to be absorbed through the microvilli and your lymphatic system. They should not bypass that and directly leak into the bloodstream. Okay, so this is called leaky gut. Now, here's how I test for it. What you're testing for is a protein that holds together. A protein that holds together the simple columnar epithelium is called a zonulin. Okay. All right, it's called a zonulin. It's a protein that holds together the simple columnar epithelium. If a person has gastrointestinal inflammation, whether it's gastritis, whether it's a side effect of, gluten stuff, if it is, whatever, the foods that they're eating, stress, you name it, doesn't matter. It all creates inflammation. And if they have this, there's a chance they're going to start to hurt the zonulins. Now, the zonulins are these proteins that also break free and start floating around in the bloodstream. And that's what I'm testing for. Do a lab on zonulins. If we see the presence of zonulins, we know you have a leaky gut. Plus, the signs and symptoms are there, right? All the usual suspects that are going to come with gastrointestinal disturbances are also going to be there. Okay. So then we start to do things to turn it around. Okay. You show them, here's what's going on. You have leaky gut. Your zonulins are busted. Now, if you really want to double check, you can do a biopsy. Okay. We can actually take tissue out and look at it under a microscope and look at the damage that way. Okay. Now, that's a more painful, expensive route, but we can do it and you can see them. Right? We would also do that if we want to look for the sprues that are a side effect of celiac disease, okay, which is inevitably an intolerance to gluten, right? So the damage that's done. Anyway, so when food starts to, and the chyme stuff and all that starts to leak through and get directly in the bloodstream, oh, look at that. It activates these guys. Boy, they're happy to come in. And when this happens, okay, the cascade of events of your inflammation, right, the cytokines, the interleukins, they start to work like crazy. So this is a very pro-inflammatory response. And all this is floating around in your bloodstream. And now you can see why people can have these adverse reactions to food, breaking out through their skin, or the inflammation goes to their joints, or whatever. Like, everybody's a little bit different how their body processes the inflammation. But at the end of the day, it's a sign and symptom and something's going on. Okay. And so once we get all these tests and stuff, we can actually pinpoint exactly where the problem is, what foods is hurting you, where the antigen antibody interaction is taking place, what particular antibody, which means we know to the extent of the inflammatory response, okay, plus the presence of zonulins, plus all of the, other labs that we did, and the questionnaires and the history and so forth. And that, I'm telling you, we got everything. Everything's on the table. Now we've got a beautiful place to start because we have everything, okay? Then we dive in and we start to put this huge fire out. Now, it takes time. I'm telling you, it takes time. Even if people have all the information, it's not like the next day they go, "Ooh, cool, now I'm going to turn over a new leaf." We're talking about a big time lifestyle change. And you have to do it in small strategic doses over time, okay, to gradually help them turn over a new leaf. All right. It is very rare for a person to just dive right in. I mean, you got to change your shopping habits. You got to change eating out. If there's a family and everybody's used to cooking and kind of eating the same meal, now you've got probably 2 meals to prepare for, and on it goes. I'm telling you, it's a big deal. And it is a little bit more expensive to eat cleaner. Okay. Now there is a way to do that more cost effective. All right. And I've seen the breakdown. A registered dietitian from, I think, South Dakota wrote a really nice article years ago on the financial part of eating healthy. And it was beautiful. Okay. Did some research and data analysis and all that stuff on what people spend on junk food. Okay. Like, for example, a Venti Starbucks Frappuccino costs like $107 these days. Okay. I'm kidding. It's not that much, but they're expensive. Starbucks is expensive. Okay. And then, the way people go grocery shopping and the soft drinks. And I mean, once they actually, how often they eat out. And here's a big one: alcohol. Man, these people, they go out and drop 60, 80, $100 at a bar, no problem, plus tip, 2 or 3 nights a week. It's like, okay. So, and I'm telling you, it included all sorts of things like that. And then broke it down what it looks like to eat clean. And at the end of the day, it actually was cheaper to eat clean than all that other stuff. Okay. So what I meant earlier by it's more expensive, that's what people will tell you. Well, it's just more expensive. It's like, well, not really, not if you do it right. Okay. So once you start to eliminate the things that you don't need and minimize how much you eat out and that kind of stuff, it's actually more cost effective and healthier for you in the long run. Not to mention all the medication over the counter plus doctor visits that they're doing to cover up the symptoms or ameliorate the pain or the dysfunction, whatever is going on. All that was calculated in there as well. All right. So point being is, people will tell you, well, it's more expensive. It's like, it's actually not. If you do it right, it's actually cheaper in the long run. Okay. More cost effective. Okay. Okay, let's do a little bit of liver. Okay. So the liver helps. Oh my goodness. Did we lose the screen share? Anyone? We're good? Okay. Okay, the liver helps with synthesis of cholesterol. Okay. Conversion of cholesterol into the bile. Salts, it produces albumin. It helps with the oxidation of drugs and toxins and alcohol. Okay, it helps with the degradation of purines. Okay, and it turns that into uric acid. Okay. The liver also stores glycogen, known as hepatoglycogen. It's a part of the gluconeogenesis process. Okay, it also synthesizes of your very low density lipoproteins. Okay, And this comes mainly from carbohydrates. Okay, your liver makes these very low density lipoproteins. It also makes your high density lipoproteins. Okay. The HDLs are known as the good cholesterol. I'll explain why in a minute. Okay, so the HDLs, they convert your apoproteins into your chylomicrons. Okay, and apoproteins are a type of protein that help make the VLDLs. And chylomicrons. Okay. And HDLs also help lower LDL levels. Okay, so that's why they're known as the good cholesterol. Okay, the liver helps with gluconeogenesis and also urea. Okay, so it's a production in the liver, and it comes from nitrogen metabolism. Okay, and then this is later excreted in the urine. Okay, and the kidneys are also involved. Okay, and that's where your blood urea nitrogen test comes in. That's the amount of nitrogen in the blood. And elevated levels can mean kidney and or liver problems, or it could mean a protein metabolism problem because, you know, it's a nitrogen metabolism because of the metabolic breakdown of proteins in the liver. Okay, so in other words, if you see blood urea nitrogen levels are off, then you work your way backwards, okay, which means you'll think kidney, then you think liver, and then you think digestive system and what they're eating. All right, so that's what I mean by working way backwards. So I've got people that come in, their skin is all broken out in hives. All right, well, let's work our way backwards. Okay, it's the skin. And then what's next? And then what's next? And what's next? And you can trace it usually all the way back to the gut and of what they're eating. Okay, now not every time. Could be because they rolled around in poison ivy. But when you're trying to link things to gastrointestinal disturbances, you know, work your way backwards. All right, your bone marrow's not working. Well, that means the stem cells aren't working, which means the myeloids aren't working right. Right, keep working your way backwards. Okay. Oh, look at that. Intrinsic factor isn't there. Oh, B12 is deficient. Oh, look at what you're eating or what you're not eating. Okay. Liver disorders. All right. Increased ammonia. So think liver. Ammonia is toxic to the nervous system. Okay. Low blood glucose levels. Okay, these are kind of in your family of, let's say, differential diagnosis. You see some of this, you should be thinking A, B, and C. Okay, so part of that formula in this case is also think liver, right? So decreased blood glucose levels, well, it could be how they're eating, what they're eating, could be pancreas, could be insulin, could be diabetes, but it could also be a liver issue. Okay. Out of range cholesterol. Decreased bile salts. Okay, increased bilirubin. All right, increase in, now this is a lab here. The LDH, lactase dehydrogenase, ALTs, AST. So if you do a liver panel lab, these are what come with that package. Okay, so earlier I was mentioning that we do labs on people as that quote unquote full physical. Well, these are part of it, right? You're going to get your liver enzymes. Now, what happens is if these are elevated, it's because they are leaking out of the liver. Okay. They're leaking out of the liver and floating around in the body. So that's why the lab picked up on them. You shouldn't really find high levels of this floating around in your body. They should stay mostly contained in the liver. Okay. Another liver lab will be alk phos. Okay, in hospitals and clinic settings, that's the slang. It stands for alkaline phosphatase. Okay. They'll have a decrease in protein synthesis. Okay. Now, that could also be a hypochlorhydria, you know, a stomach problem, but also think liver. Decrease in albumin. Okay. Protein made in the liver. And decrease in VLDL, which means they're going to be high in triglycerides, which means they risk fatty liver. Okay, so everybody try to hang in there till, you know, close to noon, okay? All right, triglycerides. And I'm going to shorten that as TG. Okay, triglycerides. All right, so when we eat, insulin activates the synthesis of lipoprotein lipase. Okay, now keep in mind, we're talking about the typical American diet, which means we eat carbs, fats, and proteins, okay? So we're just assuming in this case where everybody's eating kind of the normal diet, which means they're consuming carbs, fats, and proteins. Okay, the lipoprotein lipase breaks down the triglycerides. Okay. It breaks it down into its fatty acid component and the sugar component. Okay. The fatty acid component is stored in adipose tissue. Okay, so your fat tissue. And adipose tissue's function okay, so triglycerides, and I'm trying to do it through the lens of the triglycerides. So triglycerides are stored in the fed state. Okay, so fed, like feeding, or you feed yourself. Okay, so they're stored in the fed state, and then triglycerides are released in the fasting state. Okay, via I guess that's an LI, lipolysis or lipolysis, right? The breakdown of fats. Okay. Quick side note, this is where the ketone diet comes from. All right. So the idea is that you deprive yourself of carbs, which means you're depriving yourself of sugars. And your body does need glucose to function. Okay. The brain is a very high metabolic organ and it needs a lot of glucose. Okay. Now that doesn't mean go out and just consume the crap out of sugar. All right. But it needs it. Right. So if you're not going to consume a carb, then your body goes, hey, no problem. I can make my own. So it goes into the fat cell, brings out that triglyceride stuff. Okay. And I'm skipping a host of biochemical processes that the body goes through to do this. All right. But it goes into the fat cells. It pulls out the stored energy that's in there and converts it into a form called ketones, right? So that is what puts you in a state of ketosis, is your body is now going into the fat cells to pull out the stored stuff to now be converted into a form of glucose that your brain and body can use. So if you keep doing that, then the idea is your fat cells will decrease in size and therefore you will lose weight. Okay. So it is a thing. All right. Now that's the quick version. We could talk about 3 months on the keto diet, but there's your quick version of it. Okay. Let's see. So let me change colors here. Okay, insulin. All right, activates the transport of glucose. Okay. And is, let's see, part of this process and the triglycerides are connected. So in other words, it is very possible for you to consume a lot of carbs and it be converted and stored as fat. Okay. So that's one of the reasons why a high sugar, a high carb diet can actually cause a person to gain weight. There's a lot of data out there. In fact, there's a book out there called, I think it's simply titled Eat Fat, Lose Weight. And you're like, what? Okay. Because there's healthy fats out there. And when you look at what, some of these studies and all that people do when they consume these high carbohydrate diets, I mean, they are bombarding their body with so much sugar, I mean, it's got to go somewhere, right? And then all of a sudden, when the diet is changed and we start to get a healthier balances of carbs, proteins, and healthy fats, yeah, the person can actually start to lose weight. Now that gets into some nutrition stuff, and we really don't have much time for that. But I just want you to know, yes, it is possible to gain weight by consuming too much sugar. Another way of saying that is consuming too much carbs. Okay. So in diabetes, okay, type 1 or 2, the uptake of glucose is decreased. And so this increases blood glucose levels. Okay. So what can happen with diabetics is they have a decreased breakdown ability of triglycerides because the lipoprotein lipase was not activated. And what did we say earlier activates it? Insulin. Okay. Is not activated by insulin. And what this does is it leads to an increase in triglyceride levels, which increases fatty acids that go to the liver and can create over time fatty liver. Okay. So just because a person has high cholesterol and high triglycerides, in my opinion, it does not mean just throw medication at them, statin drugs. It also means figure out through their diet and lifestyle what they are doing that is hurting them, causing these levels to go up. Okay, so think about that. If a person is doing what we just wrote down and only taking medication, you're kind of not fixing the problem, okay, because they're continuing doing their bad habit or whatever it is that is hurting them. So, you know, on my end, of course, as a bias, I think it's important to also look at, you know, diet and lifestyle stuff. Okay. All right, I want to do a quick thing on the liver. Okay. And the whole cholesterol thing, you know, real quick. Okay, so here's the quick version. What happens is you have VLDLs, okay, made in the liver. When they leave, they're converted into LDLs. All right. And an LDL has a bunch of cholesterol in it. And this floats around your body and deposits the cholesterol in the body where it's needed. Now, keep in mind, cholesterol is not necessarily a bad thing. It makes your androgen hormones, it makes your bile salts, it helps with the integrity of the phospholipid bilayer of the cells, okay? But yes, it can also do some harm if you have a cracked and fissured blood vessel, because it's part of the repair mechanism of the cracked and fissured blood vessel. All right, so your LDLs are depositing all this cholesterol stuff. Well, the HDLs, okay, you can kind of look at them like a deflated balloon, okay? And what they do, a deflated balloon that's like a vacuum cleaner. So it's going to start to collect all of the quote and unquote extra cholesterol. Okay. So it goes around and kind of vacuums up the extra cholesterol. Now, if you can kind of look at this from a deflated balloon or a deflated vacuum cleaner bag, the more stuff you put into the balloon or the vacuum cleaner bag, the bigger it gets. So it goes from kind of deflated to really big because there's a lot of cholesterol in it. That's why the HDLs are known as the good cholesterol, because it collects all the excess cholesterol in your body and then it sends it back to the liver where the cholesterol stuff is released and resynthesized into VLDLs and then LDLs, and then thus the cycle continues, okay? So the best way to improve your HDL levels is exercise. Okay, they've even done comparative studies against medication that's supposed to increase your HDL levels, and still exercise wins. Exercise is better, okay? And then my goal with people with LDLs is to get them down to some healthier levels, but even more important, it's to decrease the inflammation in their body and improve the vascular health of their blood vessels. Okay, because we know that if you look down the barrel of a tube and you get a little crack there, that all of your inflammation stuff, the foam cells and the macrophages and the lipids and the cholesterol and the LDLs, all that's going to come in to start to repair, right? And the hemodynamics of the blood vessel, it keeps expanding and expand because fluid is going through them and all that stuff. Well, if you're not fixing the underlying inflammation and the integrity of the blood vessel, it's just going to crack again and crack again and crack again. And more of this plaque stuff starts to develop and more. And over time, oh, this is beautiful. Now we have, that's all that's left. So we have 95% blockage. So this person is not going to make it unless they get intervention, whether it be a bypass, a stent, or whatever. Okay. And this takes years to develop. Right. So now here's what's kind of funny, right? After a person has heart surgery, whether it's bypass, stents, and all that, then what do they usually do? What does a person usually do? You guessed it. They change their diet and lifestyle. Okay. So fine, at least now they're doing it. It'd be nice if they had done it a long time ago, but okay, if you cross enough lines, we have the technology and the skills and the facilities and all that to help you. But at the same time, I'd also not like for people to get there. Okay. I mean, I wouldn't want to deal with having a heart attack and bypass surgery and all that stuff. I'm really glad we have the technology if I need it, but I'd rather try to prevent. Okay. And that goes with any kind of health issue. You do the best you can to try to prevent. Okay. So I'm going to switch over to the PowerPoint. I'm going to start with chapter 36. Okay. And I'm going to go through these somewhat quick. So we're going to do, so for the rest of the day, we have 36, 37, 38, and a tiny little bit of 39. So really just three things to go through. Okay, 36, 37, and 38. Okay, I'm sharing this. All right. Okay, so these are just some terms. A lot of this is going to be vocabulary. Okay, so just know these terms, like what dysphagia is, it's difficulty swallowing. Okay, different things can cause that. A tumor, okay, so space occupying lesion, or scar tissue, okay, or some sort of congenital anomaly where the tube itself just wasn't made right. Some people do have extensions of the esophagus tube that leads into the trachea, some sort of connection there. I actually found one of these. This was years ago. We just referred out for some images and was like, whoa, look at that. Okay, it just went unnoticed for, many years. Um, okay, so esophageal pain. Okay, so this mimics angina pectoris, which is chest pain. So sometimes people go in thinking they're having a heart attack, but really they're having chest pain. And it's usually coming from some sort of stomach condition where you're getting some weird, backup of the stomach material into the tube that can cause the pain, or severe spasm. Okay, so the esophagus is smooth muscle and it can spasm, and the pain can mimic a heart attack. Okay, abdominal pain is a sign and symptom of GI tract issues. Okay, certainly abdominal pain can come from, anything, but also be thinking GI. Okay, you can get referred pain. Okay, so the nerves that come out of your spine, okay, the mid to lower thoracic nerves and the cutaneous branches that come out of the spine. So in other words, if your spine and the nerve roots are irritated because of where the nerves go, can cause visceral pain. So your stomach is fine, your abdominal stuff and GI otherwise is fine, but it doesn't feel fine because the nerves are pissed. Okay. So in that case, if that person gets spinal treatments, therapies, and other things to help reduce neural tension, then the abdominal pain goes away. Okay, this is just showing you more of that neurological innervation. So in the spine, the nerves do come out and innervate our viscera, and you can get referred pain because of a pissed off spine and or nerve roots. Okay. Your map of visceral pain, referred pain, okay, from the spine. Constipation, okay, is can be small, infrequent, difficult bowel movements. Usually very hard and difficult stools. Okay, a lot of different reasons. Could be diet reasons such as low in fiber, lack of exercise. Sedentary. Peristalsis is the rate at which food and material like that is moved through the tubes. Okay, so things go from point A to point B as they move through the tubes, and that's your peristaltic wave. And some people, that wave is declined, so it's decreased. Could be because of age, could be because of sedentary. If you want, one of the easy things to do to help promote healthy digestion is to actually move, right? So a lot of people, they eat and they get stuffed and they're like, oh, food coma. And so they just sit on the couch, right? And that's actually not good for your digestive system. Okay. Ideally, what you want to do is after you eat is actually walk. Okay. You don't have to do like actual cardio stuff, but just like a basic walk is fine, whether it's around the house or just some sort of movement. Okay. One of the last things you want to do is just sit. Okay, diarrhea. So this would be very, very loose to watery stools, and a lot of different things can cause this. It could be an infection. Okay, so in my particular world, when I help people manage, stool problems. Now, keep in mind, if I'm working with someone with, nutrition and gastrointestinal problems, and we're doing food allergy testing and all that stuff, bathroom things are going to come with the package. How often are you urinating? What's the color of urine? The different things you can find in urine. Same with stools. Okay, I've ordered stool samples to look for parasites and look for other, things that you might find in stool. So stool is valuable, even though it's kind of weird and it's different and it's gross, whatever. It's still bodily function and it's still valuable for our overall health. Okay. So, um, so if I'm working with a person with diarrhea, then at first I'm like, okay, if your body is fighting an infection, okay, then your body is purging, and that's okay. We need it to do that. So at first, it's fine. It's kind of like vomiting. If you're fighting something and your body needs to get rid of it, just let it get rid of it. However, if it's chronic and reoccurring day after day after day, now we're getting into a problem. Okay. So at first, it's okay, just like vomiting, let your body just purge and get rid of it. But if it keeps going, then now we have, it's something else. Okay. And it warrants further investigation. So sometimes food itself is creating a problem. So the inflammation from the GI system and the fast motility of things rushing through the intestines, and the body is not having time to absorb the water from the small intestine, can cause diarrhea. Okay. It could be from, different bacteria and, like if a person has traveled overseas or they're camping and they're drinking, let's just say dirty water or not treated water, that can cause diarrhea. And so here's some of the infectious organisms that you can test for. So at first, this is my world, at first it's not really too much of a concern, but, because I'm letting the body purge. But if it becomes chronic and reoccurring, then we're taking stool samples and sending things out and figuring things out. Okay. Usually at that point, turn it over to medical management. But I, order the stool, get the results, give the patient the results, and then you send them to the appropriate people. Okay. It could also be from legitimate bowel problems like Crohn's disease or ulcerative colitis. Okay. Stomatitis. Okay. Stoma is really just any opening in the body. So like the mouth and any, alimentary canal opening, they'll call a stoma. So stomatitis is inflammation of the oral mucosa. Okay. It could be from pathogens, from trauma, allergic reactions, different irritants. Okay. Autoimmune. Okay. GERD, which is short for gastroesophageal reflux disease, okay, commonly known as GERD. It's a backflow of gastric contents into the esophagus. Okay, I do find that a lot of this is what you're eating. Okay, you put an irritant food into your body, you may not be activating the actual vomiting centers, which is located in the brainstem, but you're going to activate the chemistry in the stomach to get rid of it. Okay. And so if that's the case, then we just remove the food that's hurting you. All right. So other cases could be, because of, pregnancy and other teratogens that might be getting into your system that your body's deciding. Okay. But at least in my world, we really try to dive into assuming it's a food problem, which is very common. It's what you're eating. And once we figure that out, then usually symptoms go away. Okay. If that doesn't work, then it's something else. Okay. And we keep peeling back the layers of the onion until we figure it out. A Barrett's esophagus is where the tissue is being replaced by another tissue. So columnar tissue replaces the squamous tissue. This is also a risk factor for cancer. So if a person has a Barrett's esophagus. Okay, hiatal hernia can cause gastrointestinal disturbances. Okay, and sometimes these are palpable. I have found a few of these in my day, and I'm like, well, that mass doesn't feel quite right. I don't like that. Go get it checked. So we order images, and sure enough, sometimes it comes back as a hernia. But basically, it's where the stomach is starting to work itself up through the diaphragm. Okay, so ulcers, okay, peptic ulcer disease are basically eating away at some of the tissue, okay, and it's starting to then bleed, okay, so now you have these ulcerations. You'll find that it could be a side effect of medication. I mentioned this earlier with the NSAIDs. You know, people are taking just high doses of this stuff, and you're like, come on, you're hurting yourself. There's the H. pylori. Okay, one of the reasons why I test for H. pylori when I suspect gastrointestinal disturbances and other things. And but whatever you find, of course, we're going to try to remove the provocative factor. So like decrease in the medications, or if it's H. pylori, you try to get rid of that particular bacteria to help the person. Okay. So this is showing you a picture of a duodenal ulcer. Remember, the duodenum is the first part of the small intestine. Okay, ulcerative colitis, so chronic inflammation of the rectum and the colon. And it can also lead to ulcers. Okay, your chances of cancer go up with ulcerative colitis. Okay, inflammatory bowel disease. So this covers many things can fall under inflammatory bowel disease. So the ulcerative colitis is one of them. Crohn's disease is another one. Okay, and so this one you'll usually find sprues. Okay, and no, not the sprues. That's from celiac disease. You'll find what's called a skip lesion. Okay, so when you do the contrast dye, where they put it in to image the intestines, that's where you can really start to pick up of the damage of Crohn's disease. Okay, usually affects the proximal portion of the colon. Okay, and then irritable bowel syndrome is it's kind of in that same family, to me at least. It's in that same family with fibromyalgia. Got all these problems, got all this pain, can't really find anything, so you have fibromyalgia, right? You have all these gastrointestinal disturbances, but we really can't find anything, so you have IBS. Okay, so irritable bowel syndrome. So obviously the bowel is irritated and you have symptoms. Something's going on, okay? Now, this statement here, food triggers it. Now, I completely believe that's what it is. I mean, if you guys would see the different chemicals that are put in all these foods, the fake foods, artificial, the genetically modified and all that, I mean, it is such an irritant to your, gastrointestinal system, okay? Not to mention the inflammation and all that comes with it. So absolutely, it's a thing. Okay, and now these days with some of the laboratory technology, we can certainly figure out and pinpoint with the antigen antibody interaction and so on what's going on. Okay, enterocolitis. Okay, so the antibiotic associated colitis. This is created because of an imbalance in the gut microflora. Okay, and I promise you, I'm not picking on the antibiotic world. It saves millions of lives. It's an amazing treatment. It's really cool. But at the same time, you have to be careful. If antibiotics start to decrease the healthy gut flora, then you start to create imbalances and the gut is susceptible to injury. Okay. So this would be an example of antibiotics causing the colitis. Okay, appendicitis is inflammation of the appendix. On the functional medicine side, we do view the appendix as part of our lymphatic system. Okay, so this is part, so the small intestine comes in, okay, that's the ileum, and it meets the cecum, all right? And basically, this is the beginning phases of what's poop, right? So the poop stuff enters into the large intestine. The first part is the cecum, and then it goes up, which is the ascending colon. Okay, eventually it's going to go through the transverse colon and go down the descending colon, and then the sigmoid colon, and eventually be eliminated. Okay, and so if you think about the byproducts and the toxins and the crap that's in food that your body's trying to get rid of, yes, you can introduce a lot of literally crap into that first part of the cecum. And there's so much septic stuff coming out, the appendix just, it will get pissed. Okay. So it can inflame. So that can be one reason. Another one could be because of a twisting. Sometimes people's appendix, just the way that they're built, it sits funny and it doesn't really get a good, circulation supply and that kind of thing. And it starts to inflame. Okay. It's kinked. But irrespective, whatever is causing the problem, it needs to be removed, because if that appendix ruptures, it can create a lot of problems, including death. Okay, because of the septicemia that can come with it. Okay, diverticular disease is, as you can see here, okay, where the tube itself starts to create a malformation, okay, a type of herniation in the tube itself. Okay, so if it gets infected, they'll need to be on antibiotics. Sometimes it can be fixed through surgery, especially if it forms an abscess. Initially, what we try to do is lower the inflammation as much as possible to get the tissue swelling down, okay, which means they're going to have to change their diet, okay, get rid of the foods that's hurting them. Okay, you can see a picture of the diverticula there. Okay, motility disorders. We do have one big peristaltic wave from beginning to end through your alimentary canal, right? And so for a variety of reasons, okay, whether it's stress, which would slow down the peristaltic wave, okay, or kinks, okay, kinks in the tube like adhesions, hernias, tumors, space occupying lesions, okay, so basically mechanical obstructions can cause the intestinal obstructions. Okay, a volvulus twisting of the bowels. Okay, I have found one of these, and this was about probably 6 or 7 years ago. Okay, pretty significant GI pain, and kind of long story short, nothing was really working. So I was like, okay, let's get some images, and turns out they had some twisting of the bowels going on. Okay, so the surgery was actually very successful for that to be fixed. Okay, there's an example of a twist. Okay, the intussusception, so where the intestine starts to telescope within itself. Okay, that is a surgical treatment. The person risks getting gangrene and other issues. Okay, that's where it kind of folds into itself there, telescopes into itself. Okay, megacolon. Boy, look at this. This one's awesome. Look at the size of that colon. Okay. Now that's pretty severe and significant. I've had people come in with low back pain, and we take x-rays, and you can see the transverse colon is just filled with matter. Okay, so once you pick up on that, even though that's not why they were there, it was an incidental finding, then I refer them to get some meds to really flush out that, and the intestinal stuff. Okay, but that one is huge. That's like awful. Okay, so that definitely has crossed a line of no return, but basically it's a very large and dilated colon. And, you hear stories of people that can have, 25, 30 pounds of fecal matter just hanging out in the colon. Okay, so that comes from prolonged constipation, poor peristalsis. It turns into a megacolon. Okay, malabsorption. So remember, of what you eat and how you eat can cause malabsorption problems. Okay, so that's one good place to start. All right, you can't have beer and deep fried tortillas that they break into chips, and that's your diet. I mean, that's basically empty calories. You're getting nothing. Okay, you're consuming a lot of food, but it's really doing nothing for you. Okay, so all of a sudden this person has deficiencies. They don't have, and I'm like, well, look at what they're eating. Okay, Skittles, chips, and beer all day. That's it for forever. Well, of course, there's going to be some problems. So just don't forget, what are they eating and how are they eating? Okay, but then it could be other things, gastrointestinal inflammation and mechanical problems, space occupying lesions that are causing the malabsorption. Side effects of medication, like for example, the NSAIDs, they actually do decrease the size of the microvilli temporarily when you're on the NSAIDs, which means absorption of food isn't very well. Okay, it's not done very well. All right, celiac disease, this is the one where you see the sprues. It's usually a gluten intolerant. And once we come back from our break, I want to talk a little bit about the gluten intolerance, okay, to hopefully shed some light on the buzz, right? Well, what's the whole buzz with gluten intolerant, everything gluten-free and dairy-free? Am I missing something here? Well, here's the quick version. For some people, it is a thing, and for other people, it's not. Okay, it's just going to depend on your genetic makeup and the function of your digestive system. Okay, so we'll actually talk about that when we come back. Okay, dumping syndrome is impaired gastric emptying. So the pyloric sphincter, which is the gatekeeper of that chyme we were talking about earlier, it has a dysfunction in it. Okay, so short bowel syndrome, and the word kind of gives it away, where you just do not have a long enough bowel. Okay, so that leads to malabsorption because the length of the small intestine tube buys you time to allow your body to do a lot of absorption. So if it's short, you're going to have some malabsorption. Okay, and then neoplasms. Anytime you're dealing with neoplasms, that's a red flag for cancer, or cancer is around the corner. Okay, so anywhere they find them, where it's in the esophagus or the intestine, it's just going to warrant further investigation to see how they can be helped. Okay, so once you get into your cancers, so a gastric carcinoma, these are sad cases, and that actor who played as Black Panther, I forget his name off the top of my head, but that's, he had, didn't he die from GI cancer, stomach cancer? Okay, hopefully not, you guys are not all asleep.
I think it was colon cancer.
Or colon cancer, okay. Yeah, I'm sure that was a very big shock and surprise to everyone. I mean, I'm a Marvel fan. I enjoy the Marvel films, and I remember when that came out, you're like, what? Because he did a very good job of keeping that quiet until literally till the last minute there. Okay, so small intestine neoplasms can be benign or malignant. Depending on how long the signs and symptoms continue, like in my world, right? Person comes in, GI dysfunction. Okay, is it the food they're eating? Is this allergic response? That kind of thing. But then, yeah, way in the back of your mind, am I dealing with a cancer? Am I dealing with some sort of weird mechanical congenital blockage thing? Right? So you at first kind of do your best clinical judgment. Okay. In general, it's likely what they're eating. But if they're not responding well, then it's something else. Okay. And if symptoms get really bad, then we just go ahead and jump to some of the fancy images right away. Okay. Polyps. So these are little sac-like things that start to develop in the intestinal walls, usually found with a colonoscopy. Okay. And colonoscopies, I think, are recommended after age 50. Okay, you can get them at any time, but certainly after age 50, it doesn't hurt to go get colonoscopy and get that checked. Okay, and then more on the cancer thing. At some point, if symptoms are bad enough and you get enough of the fancy images and or biopsies to confirm, then we're dealing with some form of cancer. Okay. All right, so let's take a break. We'll come back at 1 o'clock and finish up the other couple of PowerPoints and then talk for a minute on, some celiac and gluten stuff. Okay, so see you in about an hour.